they came up with some guidelines. So here's my question to you. What did the NCEP guidelines in 2002 say was the optimal LDL level? The optimal LDL level. Go ahead and vote. Hattie, I got all these questions for you.
Thank you.
All right, let's show the answer. So most people got the answer. They said that, as you'll see in the next slide, that optimal LDL was less than 100. And in fact, it wasn't until you got up to my pointer's dead, wasn't until you got up to 160 LDL that it was called high. And I hope I can convince you before you leave this room that that is insane, okay? But that's what it was. And they say, who ought to get treated? Well, down here, if you have either atherosclerotic disease or risk equivalence, that was diabetes fundamentally, or a very high risk score, then you should be under 100. If you had multiple risk factors without that, and here are the risk factors, smoking, hypertension, low HDL, family history or age, then you went into the Framingham risk score, and if you had a Framingham risk score of more than 10% risk, then in fact you ought to get statins. And low risk, under 160, nothing at all. Okay, and here's the Framingham risk calculator, and you can see the variables that it took into account: age, gender, total cholesterol rather than LDL, whether you smoked, and if you had high blood pressure or were on treatment. So keep that in mind. That was the Framingham risk, and you'd put in the numbers for any individual patient, and if it came out that they had a 10% risk of an event, then you over a course of time, then they ought to be on statins. So the next thing that came along took 11 years for a second set of recommendations as data was pouring in. And it was often said took 11 years because people couldn't agree. But finally, after 11 years and people interacting like porcupines mating, they came up with a guideline document, okay? And to say that this guideline document was controversial doesn't even begin to express. As a matter of fact, I have an image here after the new guidelines were announced. Will that play? Here it is. So the new guidelines were announced, and this was the reaction. You know, it was. Okay, you can see they were duking it out there. So I no longer have a pointer, but anyway. So the next question, all right? The new guidelines, the 2013 cholesterol guidelines, call for pharmacotherapy of which of these groups of patients? The first one, anyone with atherosclerotic disease of any kind, even peripheral vascular disease. The second one, patients who have nothing else but an LDL greater than 190. Third one is diabetics over the age of 45 with an LDL of greater than 70 now. The fourth one is patients with a risk score of 7.5% per 10 years, not 10%, with an LDL of greater than 70, or all of the above. Oh, this is for me to vote? I know the answer. Okay. All right. Let's show the answer. There you go. All right, so everybody's familiar with the guidelines, all of the above. That's what they did. It was really an interesting thing. The panel said, what we're going to do is we're only going to deal with evidence-based that is randomized clinical trials, prospective randomized trials. And anything that hasn't been studied, we're not going to recommend, regardless of how logical it is. But if it hasn't been studied, if there hasn't been a randomized clinical trial, we're going to ignore it. And based upon that, they said, we come up with these recommendations that you treat the patient. You treat somebody who's in each one of these or any one of these groups, and that's it. And of course, the most controversial, and the one we'll talk about for a couple minutes, is this last group. No signs of disease, okay, with an LDL of greater than 70, but a high risk score by a brand new risk calculator, not the old Framingham risk calculator. Okay, so these are the 4 treatment groups. I just read them off to you. You all knew that anyway. And here's the new risk calculator. And it's got the Framingham things in it: gender, age, HDL, total cholesterol, blood pressure. But in addition, diabetes and ethnicity are put in. And this was based, the new risk calculator was not based on Framingham data, on 50 years of Framingham data. It was based on 4 randomized prospective trials. Based upon that, they figured out an algorithm. You put in your numbers, and that's how you come up with your risk score. And they settled on 7.5% risk over 10 years. They said there were other things you could consider, but they really poo-pooed them. If your LDL was greater than 160, or if you had a family history of premature coronary disease, which was less than 55 in males, less than 65 in females, CRP, or coronary calcification, they poo-pooed, you know, well, maybe as a possible. You just touched okay. And ankle brachial reflex. Okay, so this was their algorithm. In the interest of time, I'm going to move on. Now, those were the people who should get treated. And then the next question is, with what? You know, what agents and what dose? And they took the position that some people should get high-intensity statin therapy, and the 2 agents that would and that's an average reduction of LDL of about 50%. And the 2 agents and doses that could do that is atorvastatin, atorva at 40 to 80, or Rezuva at 40. Moderate intensity was lowering the LDL 30 to 50%, and here's the agents and here's the doses, and they didn't really deal with low intensity. So that what they would do is they'd say, here's the groups that should be treated. So if you have coronary disease, then it definitely should be high intensity unless you're over 75. If your LDL's over 190, it ought to be high intensity. But for diabetics, they were at moderate intensity unless they had a 7.5% annual rate. So that was the scheme. So what did this new thing? This is what everybody's talking about. You go to a cardiology meeting, and if you hear a lot of shouting, then you know that they're discussing the new cholesterol guidelines. So they said, you don't have to measure LDL anymore. Don't measure it once just to make sure the patient's taking the drug, and that's all. No LDL targets. They said non-statin lipid-lowering drugs like nicotinic acid and whatnot, don't bother with them. There's no evidence that they work, that were acceptable to them. They were much more cautious in using statins in people over the age of 75 than the original guidelines have been. They really poo-pooed the surrogate markers of atherosclerotic disease like coronary calcification or carotid intimal medial thickening. And of course, the biggest thing was they had a new risk calculator. And that was a huge thing because this new risk calculator, by various estimates, would result in an additional 12.5 to possibly as many as 45 million additional individuals indicated to receive statin therapy over the 2002 guidelines. Now, you know, I think I've read every manuscript on this, unfortunately, and I think there's a consensus that it could be as high as 12.5 to 15 million additional people. And then the question becomes, is that good or bad? Is it good or bad to have all those people? But, you know, it could be 1 in 3 Americans taking statins. Worldwide, it could cost $1 trillion a year. You know, a big money. So immediately, you know, simultaneously as the guidelines were being announced, publications were coming out criticizing them. People were already ready for it. And so what were the criticisms? Well, the biggest one was the risk calculator. And he said, this risk calculator is no good. It way overestimates the risk of events. Too many people receive statins, and there'll be a ton of side effects. And we'll talk about diabetes especially, because diabetes has turned out to be a very significant consideration. There's no question that statin therapy is associated with an increase in diabetes. And of course, myalgia, cognitive dysfunction, there's a great one. You know, there are studies that indicate that people on statins have more cognitive dysfunction, and there are studies that say it's less cognitive dysfunction and it's good for Alzheimer's. So how do you know where to come down on that? Liver and kidney damage are reversible, you just have to monitor. And the last one, and I'm sure all of you can identify with this, is that all these people, once you give them statins, they're not going to watch their diet or exercise, right? How many times have you been at dinner and somebody orders dessert and says, I'm just going to take an extra dose of statin? You know, that whole concept. So that's a worry, that if you make it too easy for people to have a low LDL level, they're not going to do the other things they should be doing. There were also some kind of snide criticisms of the guidelines. 20 of the 46 recommendations had no data based on expert opinion, but these were minor. 6 of the 15 authors had ties to the pharmaceutical industry, and a number of credible medical groups refused to endorse the guidelines, the Endocrine Society among them. So immediately, the risk calculator was attacked because it was the risk calculator that resulted in 12.5 to 15 million people who are asymptomatic receiving statins. And in this very well-quoted study by Paul Ritger and Nancy Cook, they took 4 randomized epidemiological studies, the physician health study, the nurses health study, the MESA trial, and they compared the number of events shown in blue with, over the years, compared to the number that would have been predicted. And you can see in each and every case, the number of number of events that would have been predicted by the new risk calculator exceeded the number of events that were actually observed. And so therefore they said, these data prove conclusively that the risk calculator is worthless. And the brouhaha continued. So, not to be undone, you know, the people who generated the guidelines came back and they said, well, we've got an explanation for that. The whole problem was not that the event rates that we predicted were too high, but the event rates you observed were too low. The populations in your studies were too healthy, or they had less intense surveillance, so not all the events were detected. Or in the populations used, there was more statin use, more revascularization, so the number of events, of course, went down. And in some of these studies, the follow-up was only a year or two. So that, in fact, the contention was that the studies that Ritger used were inappropriate to compare for a real-world population. Now, I don't have the answer for you, but those are the issues. Diabetes and statins, what to know about that is that, in fact, on average, if you treat 255 patients with statins for 4 years, you get 1 additional case of diabetes. And in fact, it turns out that most of these cases are people who had impaired glucose tolerance at baseline and then got bumped up a little bit into the diabetic range. However, in doing that, you prevent 5.4 major vascular events in those same patients. The other thing to remember is that the effect of diabetes appears to be dose-dependent. Now keep that in mind, because if it is dose-dependent, and that's what the data indicate, then probably we'd want to use the lowest dose of a statin that we could to get the beneficial effect, and therefore we'd want to measure LDL, which we're told not to do. And here's what they said. They said, this is from the guidelines. Therefore, given the absence of data on titration of drug therapy to specific goals, no recommendations are made for or against specific LDL or HDL goals. LDL levels and percent reduction are to be used only to assess response to therapy and adherence. Okay? So, what are the pros and cons? Because this is a major contention, pros and cons of measuring LDL, and some of this is my own. Well, reasons not to do it. One is they told us not to do it, but the second thing is that if somebody starts with a low LDL, let's say 80, 85, then that patient still would benefit if they meet the other criteria. And somebody say, well, you know, I know my LDL, it's 80, I'm happy with that, I'm not going to take therapy. And the second possible problem is if you can't get the LDL down with a maximal dose of a statin, you may use something else that really is not valuable. On the other hand, in favor of doing it is that LDL targets have been shown in a number of studies to be of value in high-risk groups. Studies like Treat to New Targets and the COURAGE trial, which was one of our biggest ones, atherogenic lipidemia can alter the drug regimen. You get the LDL down a little bit, but they still have high triglycerides. And as I say, you know, the diabetes issue, you may as well use the lowest dose possible. I think, my own opinion is that there's adequate evidence to justify the continued use of LDL targets, and I do that myself. And here's some reason why. Secondary prevention, LDL level plotted against events, and you can see as the LDL goes down, the events go down in a linear fashion in all of these studies down to LDLs of about 55. Here for primary prevention, putting in the Jupiter trial data, again, a linear relationship. Well, if you knew this, why not measure the LDL and get it down as low as you can? So what's a normal LDL? What's a normal? Is it 100? Is it 70? Well, here's some data for you to think about. When we're born, our cord blood has an LDL of 50 before we start on our diets. People who have very, very low LDLs, hypobeta-lipoproteinemia, have normal survival. LDL receptors are 50% saturated with an LDL level of 10, nearly 100% saturated with an LDL level of 20. Most mammals that walk, virtually every mammal that walks the face of the earth has an LDL of 50 to 70, and if you can find hunter-gatherers anymore and measure their LDL, it's almost always 70. So, I mean, you look at this, and why in God's name should anybody think that we ought to have an LDL of 100? I mean, we're not born with it, hunter-gatherers don't have it, other mammals don't have it. So, I don't know what the answer is, but my LDL is 70. Okay, so, you know, there's some data, and I was I was still the editor of JACC. I accepted this manuscript. It's a really neat study. It was a huge number of patients. I forget, I've got it done. And they had these CTAs, coronary computed tomography angiogram. So you knew who had coronary disease and who didn't based on the CTA. And they had that for like 100,000 patients. And then they said, well, did the 202 guidelines better predict the people who should have statins based on their coronary anatomy, or did the 2013? And the answer is 2013 by a mile. And you can see, here's the sum stenosis score, the number of coronary lesions and how bad they were. And more patients would be treated in the red line based upon the 2013 guidelines than based upon the 2002 NCEP guidelines. So to me, that's anatomic validation of the fact that the newer guidelines probably are treating people who ought to be treated. And interestingly enough, in this study, the 2013 guidelines resulted in a larger number of people who didn't have disease who wouldn't have been treated. So I think that's a strong, strong point for the new guidelines. Now, based upon this, in San Diego, you've heard we've got this Be There campaign, to be there for your relatives, and it's a collaboration of the entire community, virtually every institution, Sharp and Kaiser, the community clinics, UCSD, of course. Here we are posing for a picture. And the Be There concept is that you're more likely to change behavior and take care of yourself for a loved one than for yourself. Here, a father dancing with his daughter at a wedding and saying, take care of yourself so you can be there for your daughter's wedding. And so with this group, we applied for the Innovations Award Round 2 grant, proposing that we could reduce heart attacks and strokes in San Diego. We proposed we could reduce it by 50% based upon some data that Jim Duddle helped get for us from the Archimedes modeling. And so we're going to study 4,000 patients and hope to save the Medicare and Medicare Trust funds nearly $850,000. And there's 4 points. First, it's a regional collaborative to help the doctors. And to do that, what we're going to do is provide treatment bundles and coaches. The coaches, of course, are going to help the patients, and the patients are going to get incentive material to take care of themselves. And we have a technology group to study these new devices for wireless monitoring for changing behavior. So I'm rushing because there's a guy in the back who keeps holding up signs. I'm trying to ignore him, but he keeps, he's waving them and everything like that. So, but I still haven't exceeded my time, I'm happy to say. So anyway, we applied for this grant and we've got it. And San Diego, Hattie started the first RightCare down in San Diego. We wouldn't be here if it wasn't for Hattie. We've been a step ahead because of her, a couple years ahead. We've now got some government funding. We've got all the healthcare groups in the community have come together, at least the doctors have. The administrators, they don't always get on with one another, but and we've now funded to see if a community effort can do. And what's really even super about this is that if we save Medicare money, the idea is they're going to give the money back to us if there's fewer heart attacks and strokes. And we're trying to set up a model where the money would come back to this Be There group and be divided. Now, we haven't done that. That's in our mind. But we would become, de facto, the first accountable care community in the United States. It's really pretty interesting and exciting. So here are my final thoughts on this. Don't raise any more time cards. I really think there are many positive aspects of the new guidelines, but there's a number of questions that exist, especially about the new risk calculator. And so, for me all right, stay with me for another minute or two. I think a reasonable compromise, if you're unsure, might be to go back to the 10% using the new risk calculator. You're still going to treat a whole lot more patients. I continue to think there's a value in monitoring LDL, and I'd urge everybody to do that, and especially because there's a new class of lipid-lowering drugs called PCSK9 inhibitors, protein convertase subtlysin kinase inhibitors, and they can lower LDL 50% on top of statins. On top of statins, we may put cardiologists out of business, and if you can do that, you have to measure LDLs. I can't see any other way. But remember always that all these guidelines, everything I've said in the last half hour, that it all is superimposed upon lifestyle modifications. No ice cream, bacon, cheeseburgers, and the guidelines emphasize that individuals are different. The risk they're willing to take are different. And in the final analysis, it comes down to a discussion with a physician and their patient. My final slide. Born 1914, gave up smoking in 59, gave up booze in 73, gave up red meat in 83, and died anyway in 91. Thanks very much for your attention.
Thank you, Dr. DeMaria. I just want to add one thing to your San Diego example of accountable communities for health. Some of you know the state has put in for a CalSIM grant, State Innovation Model Grant, to the government, and we should hear actually possibly next month about that. Our request was for $100 million, and we may not get all of it, but hopefully a substantial portion of that. Part of what went in was some money to jumpstart up to 3 of these accountable communities for health in California. San Diego, obviously, it sounds like will be certainly an applicant for that. Should we get the grant? But there'll be at least 2 others as well. And some of us are working now in a subcommittee to develop some of the criteria for that, the eligibility, and also doing evidence-based reviews of diabetes and heart disease and asthma. And we'll be putting out a summary of that for applicants, so you don't have to do that work as a startup. Can focus on other aspects of the proposal. So keep your fingers crossed. Absolutely. So I'm going to ask Hector to come up and facilitate our next session on innovations. I've got to step out for a while, but I'll be coming back later on. So Hector and I invite up then the innovators for our next session.
So while the speakers are getting oriented, I'll just take a minute as we want to keep on time to introduce the speakers. This next session is going to be on diabetic patient care for myocardial infarction and stroke avoidance, one independent practice association strategy for activating high-risk patients deploying pharmacists. We've heard a lot about pharmacists today, and so this presentation will unpack that. We are fortunate to have 2 very experienced individuals talking about their experiences in implementing pharmacist models. Andrea Del Coro, who's a pharmacist and director of clinical pharmacy services at Greater Newport Physicians Independent Practice Association, and is on the planning committee for the LA University of Best Practices, as well as Adam Solomon, who's the chief medical officer for Memorial Care Medical Foundation. Take it away.
How do you follow up that last talk? Thank you so much for letting us come and talk to you about our active diabetes program. By way of disclosure, I have to admit I've only been with the organization for 2 months, so I wasn't present for the implementation of this program to begin with, but I'm honored to be able to talk to you about it today. So, for any of you that have started any kind of program, I'm sure you experienced that what you thought it was going to be like at the beginning and what it turned out to be at the end wasn't always exactly the same. So it's a bit of a journey, but there are usually lessons learned along the way, and so we may pick up some of those during this discussion. I wanted to tell you about our organization. Greater Newport Physicians is an independent physicians association made up of about 1,000 independent physicians, a fifth of whom are primary care, and nearly all of them are exclusive with GNP. They started in 1985, and they take risk for 85,000 patients, and you can see the split between commercial and senior. For those of you who aren't familiar with Newport, it's down in Southern California, and their offices are spread along the coast from Long Beach down to Laguna, just south of Los Angeles. I'm representing Memorial Care Health System, which is a not-for-profit integrated health delivery system, which is comprised of 6 top hospitals down in Southern California. And they are also composed of the Memorial Care Medical Foundation, which is the Memorial Care Medical Group, and Greater Newport Physicians IPA. So a few years ago, the leadership of GNP was just brainstorming, thinking about things that they could do to improve the quality of care that they were providing for their patients, and also at the same time to try to make the lives of their physicians, who are starting to get overwhelmed with so many more requirements, just make their lives a little bit better. So thinking about the different disease states that they could approach, of course what came to mind was diabetes. And I think for most of the people here, the reason for selecting diabetes is relatively obvious, but I did want to go through some statistics just to support their decision. And these are California statistics. About 14% of Californians have diabetes, which is a 32% increase over the last decade, and more concerning than that, about 41% of adults are pre-diabetic. And of course, California has the greatest number of new cases of diabetes annually in the United States. Not only is the prevalence high, but the cost is high as well. The total cost just in California of caring for diabetics is approaching $25 billion. And each diabetic's cost is about $10,000, so if you divided it up by every man, woman, and child, we're talking about a $700 hidden tax to us all. So the concept of doing something for diabetes came, but the ability to initiate a program caused a little bit of a stumbling block. This is an independent physicians association. They didn't have a clinical team to implement the program, and there really wasn't the financial backing at the time to do it. So it sat on the back burner until Blue Shield of California came out with a request for a proposal for organizations that wanted to collaborate and improve the health of the population in their area. And at the time, Greater Newport Physicians had a very good relationship with Hoag Hospital, which is right in the middle of Newport, and they decided to collaborate and address this issue, submitted the proposal, which was accepted, and hence the Active Diabetes Program was born, and this was to be a collaborative project between Hoag Hospital and Greater Newport Physicians, funded by this Blue Shield grant. The vision was that this was going to be a team approach to care. There'd be a pharmacist, social worker, nurse practitioner, and dietitian, all working along with the primary care physician to surround the patient, basically a patient-centered medical home for diabetes. And the idea was to have each clinical member of the team doing what they do best, really working to the top of their license and taking some